Hello friends, now I'll be discussing Grand Test 181 and I'll be discussing medicine questions which are from 132 to 153. Okay, in addition to that, I have extra for you. I have written a book, Medicine Simplified, which is nothing but Minnie Harrison. It's a textbook, ideally suitable for undergraduate and those who are preparing for PG enters. I also have Medicine Essence. It's a question bank for interns and post-interns. And I have also recorded complete medicine, which is available on eGurukul app. The recorded lectures, they're fully all based on 20th edition of Harrison. If you see this app, you don't need to read anything else. With this small introduction, let's come to the question number 132. Well, we are getting 22-year-old male who has the lumbar sympathetic block as treatment for reflex sympathetic dystrophy. And I'm sure you have read this question. The answer to this question is B, Bombay. The question is, what is the incorrect about this statement? Well, first of all, you should know, we got chronic renal pain syndrome. We have two types of this pain, type 1 and type 2. As far as type 1 is concerned, this is so-called reflex sympathetic dystrophy. This is type 1. Okay. Casualgia, this is type 2. So the answer B is not. That is not called as syndrome 2. That is type 1. Well, whenever we have this type of patient, whenever injury is there, we always investigate for type 1 and type 2. As casualgia is defined as nerve injury is identifiable. Okay? Nerve injury is, whenever nerve injury occurs, that we call as casualgia or so-called chronic regional pain syndrome type 2. And now here we have regional dystrophic syndrome, which is type 1. Here the best treatment is a epidural indwelling catheter for continuous infusion for local anesthesia is used for management of this case. In fact, this patient has already come for this only. Already clue has been given the question only that we have a patient who has come with the regional sympathetic block. So what type is this? So we are dealing with type 1 where we have to give block as the main treatment. Now we talk about question number 133. In the 133, we have a marathon runner and who has an occasional missed beat. If the ECE shows, what is this? This is nothing but Wenke-Beck phenomenon. Now, what we really get in Wenke-Beck phenomena? Let's look into this ECG. This is the PR interval. 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 So what we are finding, there is progressive increase in the PR interval in the subsequent beat till a P wave is followed by drop of QRS, again the same cycle start. So you can see P, 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 and these are the PR interval, what is I have written, PR interval, okay. So this is Wenke-Beck phenomena. So let's talk more about heart blocks. Well, heart blocks, we have first degree heart block. What is this? This is normal recording. And this is the PR interval and not PR interval. And the normal PR interval is between 0.12 to 0.20 second. And if the PR interval become more than 0.20 second, that is first degree heart block. Then we talk about second degree heart block. In second degree we have two types, 2A. 2A is also known as Mobitz type 1. Okay. Point to note it that the Mobitz type 1 should not be confused with first degree heart block. Now what happened in this, as I discussed in the question also, we have a PR interval, then in the next PR interval, then we have a PR interval, then PPQRS. So there is a progressive increase in the PR interval till AP is followed by a drop of QRS in the same cycle start. This is morbid type 1, also called 2A block. It's a benign condition. Type 1 is also, type 1 heart block is also a benign condition. Now we have type 2B block. And this type 2B block is also known as morbid type 2 block. What we get? PPQRS, PPQRS, PPQRS. The fixed number of P wave followed by one QRS. Like in this case, we are getting 2:1 block. This is a dangerous condition because this can go into complete heart block any moment. And this block can be 2:1, 3:1, 4:1, whatever block ratio can be there. The fixed number of P wave followed by QRS. Then we talk about third degree heart block, so-called complete heart block. Here P and QRS are beating independently, but PP interval is constant and RR interval is constant. But there is no correlation between P and QRS. This is complete heart block. These two things, they need pacing because they can go into, of course, they can, this is the can lead to syncopal attack any moment. So now, question 133 answer is A. Question 134. Well, we have a 65-year-old diabetic person who already has a creatinine of 1.6 and he was started on ACEI and also spironolactone for congestive heart failure. And now the potassium is 7.2 milligrams per liter. What is the most likely cause of hyperkalemia in this case? I think it's a pretty easy question. In fact, this question came in the Aiims exam also. The best answer of this is drug-induced. Why? There are two drugs that this patient is taking which both can lead to hyperkalemia. One is ACEI. What are the side effects of ACEI? Most common side effect is cough, dry cough. Otherwise, it can lead to skin rash also. It can, and one of the dangerous side effect is angioedema. And it can lead to hyperkalemia. It's a very frequently asked question. And this drug is contraindicated in pregnancy with hypertension because this drug can lead to fetal wasting. It's not used. Then we have another drug, spironolactone, which is a potassium-sparing diuretic. We know very well. And it is a aldosterone antagonist. Okay, and that also lead to hyperkalemia. Now, I have a question for you. Stop the video, write down the answer. Very recently, we got another drug, which is again a aldosterone antagonist, just like spironolactone. But the only advantage of that drug is that that does not lead to gynecomastia. We know very well that spironolactone is the one drug which can lead to gynecomastia. Write the name of that drug. Well, I am sure by now you have written the answer. The answer of that question is Renal. Okay. So the question number 132. What about other options? Worsening renal function, does this never happen overnight? Okay. Uncontrolled diabetes is never a cause of hyperkalemia, so suddenly. Statin-induced rhabdomyolysis doesn't occur like this. And when this rhabdomyolysis occurs, there is a strong history, and that has to be taken for a very long time. This never occurs overnight. Out of these, this is the most appropriate answer. First answer should be D. Should be always the first choice in this case. After that, we talk about question number 135, empagliflozin. Well, What the mechanism of action is? It's a renal glucose transport inhibitor. Okay. So how does the drug act? Let's learn the basic concept. The basic concept goes like this. This is the nephron, and we know very well in PCT, almost 100% glucose is absorbed here. G for glucose is absorbed. Now, when we give this empagliflozin, which is nothing but a type of renal glucose transport inhibitor, it will prevent reabsorption of glucose here. That means large amount of glucose will go out of the body. The glucose will go out of the body, that will lead to low sugar in the blood. But as a large amount of blood sugar is going out, to what the expected side effect is diuresis or polyuria. Because we know very well the glucose acts like a osmotic diuretic. What else are the side effects? It can lead to UTI. And remember, due to polyuria, patient can even develop dehydration. Dehydration can occur in this patient. And that in the recent side effect which has been implicated are, it can lead to limb ischemia also. Now, extra add knowledge for you, the newer drugs which have been approved for a diabetes are, bromocriptine has been approved as a new diabetic drug. Even hydroxychloroquine has been approved as an anti-diabetic drug. Colsavelum, which is a bile acid sequestrant, has been approved as an anti-diabetic drug. So they are the newer drugs for diabetes. Question 136. We are getting 45-year-old patient with bloody nasal discharge and recurrent upper respiratory tract infection, and he developed palpable purpura with hemoptysis, and CT scan shows multiple cavities. What is the most likely diagnosis in this case? Well, if you look at the CT scan also, we are getting multiple cavities, and we are having patient which has got upper respiratory tract involvement and lower respiratory tract involvement in the form of hemoptysis. The best answer in this case should be venous granulomatosis. What about Kawasaki? Kawasaki is a disease of children. It never occurs at the age of 45 years. This is ruled out. What about tuberculosis? Can it be there? But in tuberculosis, normally nasal discharge is not a feature. And cavitary metastasis is very unlikely because even they will not present with the nasal discharge, and venous granulomatosis is the best answer. So let's talk about venous granulomatosis. It has got classical triad of upper respiratory tract involvement, lower respiratory tract involvement, and renal involvement. And due to upper respiratory tract involvement, there may be nasal discharge. And due to lower respiratory tract involvement, patient may have hemoptysis. Cavity formation can occur. Renal failure is a feature. Classically, in these cases, we get P-ANCA antibodies. Sorry, in this case, we get C-ANCA antibodies. Now, what are the conditions where we get P-ANCA antibodies? So, P-ANCA antibodies we get in case of microscopic polyangiitis. We also get in Churg-Strauss disease. We also get in Goodpasture syndrome. We also get in inflammatory bowel disease, that is ulcerative colitis and Crohn's disease. There are a few conditions where we get P-ANCA antibodies. And treatment of venous granulomatosis is corticosteroids. Now, I have a question for you. Stop the video, write down the answer. Now, what type of gums we get in case of venous granulomatosis? Well, I am sure by now you have written the answer. The answer is you get strawberry gums. And one more question, stop the video. In which condition you get strawberry tongue? Strawberry tongue you get in case of Kawasaki disease. So there are extra information for you. Now we talk about question number 137. That is Vischer-Eldrich syndrome. All are true except in this case. The answer is red cell abnormalities. Well, as far as Vischer-Eldrich syndrome is concerned, it's a hereditary disorder. It's a triad of eczema, immune disturbance, and thrombocytopenia. P for platelet, the platelet count is reduced, the classical triad. Okay. So in this case, RBC abnormality is not a feature. Now I told you that in this case there is immunodeficiency is there. So what is the problem that we have? First of all, the platelets, what I was talking to you, what platelet abnormality? They have a small platelets. P for platelet. Eczema is a feature. What immune deficiency occur in these patients? In immune deficiency is concerned, there is reduced IgM, there is increased IgE, but IgG and IgA, they are normal. There is also T cell dysfunction. Okay. And there is one more thing that we in the platelet, not only they are small, they are even aggregation is also impaired. Platelet aggregation is reduced and that tend to have bleeding tendencies. Question number 137. What is the mechanism of action of pentasaccharide? So let's learn. In fact, we learned about mechanism of action of all newer anti-clotting drugs. The newer anti-clotting drugs are as follows. Low molecular weight heparin. We have pentasaccharide. And we have direct thrombin inhibitor. So-called DTI. There are plenty of new drugs, but before that, let's learn the mechanism of action of each one of them. The table, when you see to that, it looks very difficult table, but don't worry, I will make you revise the entire table in just 5 seconds. You can also write 5 seconds. So we talk about mechanism of action. Factor 10A inhibitor and thrombin inhibitor. Example of this drug are enoxaparin, tinzaparin, deltaparin. Then we talk about pentasaccharide. They inhibit factor 10A. Example are fondaparinux, idraparinux. Then we talk about thrombin inhibitor. So obviously, if I have to talk about mechanism of action, the action will be it inhibits thrombin. Then let's talk about example of this drug, bivalirudin. Leprodine, Dabigatran, Zymelgatran. This is a list in front of you. Okay. Well, as I told you, the look at this list looked very dangerous. Okay, I start sweating when you see this list. But at the same time you say, but you said, sir, we'll revise in only in 5 seconds. Yes, I'll keep my promise. So first of all, let's see how they act. Direct thrombin inhibitor. So obviously it will be inhibiting thrombin. Easy ho gaya, yaad ho gaya. Then it is pentasaccharide, penta and 10, penta 10, easy. And what was low molecular weight parent? Aha, both. So this is thrombin, this is 10, both. So we can sing a song. Thrombin, 10, both, easy. Now, names look very dangerous, but don't worry, I'll make it very simple. What is this? This is low molecular weight, heparin. This is enoxaparin, tinzaparin, deltaparin. कल को कोई नहीं आ जाए, ding dang, parin. So all parins are here. It's very easy. Now this is pentasaccharide. Fondaparinux, idraparinux, easy ho gaya. Now we talk about the third category. They are bivalirudin, leprodin, dabigatran, zymelgatran. So we can sing a song, parin, parinux, then gotten the entire table. We can sing a song. You also sing a song with me. They are thrombin 10 both. Repeat behind me. Thrombin 10 both. Parin, parinux, then gotten. Very easy. You will get one question in the coming exam. It's an all prospective new question. So again, a simple poem, but you can remember nursery rhyme we used to speak when we were in nursery classes, and after that, for the first time, you are making some rhyme like this. Thrombin 10 both, parin, parinux, then gotten. We could revise in 5 seconds, as I promise you. So the answer of question number 138 shall be B, Bombay. Now 139. So a lady delivered a normal vaginal delivery, was discharged, and third day she came back with fever, tachycardia, seizure, fundus shows papilloma. This is the classical thing that we get in case of cortical vein thrombosis. Why it is the best answer? Let's analyze. Well, can it be subarachnoid hemorrhage? The possibility is less. Why? It is a sudden onset. It's not a 3 days history. Sudden onset, instantaneously, severe pain, never experienced before. And fever is not a common in this case, unlikely. Migraine, unlikely, because migraine again has a sudden onset, but that again, fever is not a problem. It's not seen. Seizures are not seen in migraine, and even papilledema is not a feature of migraine, ruled out. Now 2 things are left. One is meningitis and other is cortical vein thrombosis. Well, in this case, they just mention about fever, headache. There is nothing mentioned about neck rigidity and photophobia. Now, important feature of this condition are neck rigidity. Okay. which is not there in case. And one more important problem is photophobia. Photophobia means you throw the light on the eye, the patient tend to resist like this. Kernick sign is positive. Nothing of this sort is there. So this also ruled out. Then the final thing, which is a very common problem, is cortical vein thrombosis or deep vein thrombosis is a possibility in this case. Okay? Well, cortical vein thrombosis is it can occur in any condition where there is anything which is pro-thrombotic. Like pregnancy, oral contraceptive pills, PNH, factor 5 laden, polycythemia vera, essential thrombocytosis. So anything which can lead to. And one of the kind of picture given in the question, this is the most likely to occur in cortical vein thrombosis. Hence, this is the best answer. Question number 140. Here we are getting a 53-year male presented with severe pain, and the ECG shows ST segment elevation in lead 2 V2 V6. All can be done except, well, let's take, patient has acute MI. Acute, what type of MI is it? It's a anterior wall MI. How do you know anterior wall? Because it is V2 to V3. V2 to V3. V6, this is anterior wall. Now a question for you. Well, in the ECG they just mentioned about chest leads. Anterior wall MI I'm saying. Now the question for you, stop the video, write down the answer. Which other lead will also show this type of ST segment elevation? Write down. Well, I'm sure by now you have written the answer. Answer is other lead that will be showing is AVL. Okay. And AVL, this indicate lateral wall. It will also see in lateral wall also. Where else we can see? We can also see in L1. L1. So these are findings where we'll see. Well, if the patient comes to you with acute MI, we give aspirin. Aspirin is an antiplatelet drug. And if you use aspirin in the early intervention, you reduce mortality by 30%. It's always the first line treatment that has to be given in case of acute MI. We give beta blockers. Why? What's the role of beta? They reduce the heart rate. They reduce the heart rate, they will reduce oxygen demand. Oxygen demand is reduced. Okay? Well, we want already in MI case, the oxygen supply is reduced, the oxygen demand reduced, it must be given. Tissue plasminogen activator can be given because patient has problem of last 20 minutes only. And the patient comes within 3 hours. It's the best time to reperfuse the myocardium. This we will give as a disease. There's no role of hydrocortisone in the treatment of acute MI. Absolutely no role, except that when we give any especially streptokinase, then we can give steroid only if this allergic reaction is there. Otherwise, this is not the first line treatment of a case of acute MI. Hence, by our rule out technique, D is the best answer. Well, now we talk about question number 141. This is a little tricky question that in case of acute renal failure, dietary protein should be restricted in which of the patient? All patients with increased BUN, all patients with creatine or azotemia is advanced and dialysis is not an option. Out of all these, this is the best answer. At a one glance, every answer seems to be correct. But in the exam, you have to choose exam. Remember, one more thing you got to remember. In the exam, examiner never says choose the right answer. He says choose the most appropriate answer. Again, I come back to the same question. I made a statement. at a one glance all appear equally good. Patient is renal failure, definitely you are to reduce protein intake. BUN is already very high, you have to restrict protein intake. All patients creatinine very high, you have to restrict protein. But this is the best answer because azotemia is getting advanced and dialysis is not a feature, then we have to restrict the protein. Hence, by all rule-out technique, this is the best answer, right? One more thing, extra knowledge for you. BUN is produced by exogenous proteins and creatinine is produced by endogenous protein. Now, you stop the complete intake of protein. You make protein 0. Then what will happen? Question for you. I got one patient with chronic renal failure and we are just giving him carbohydrate diet. And what will happen to his BUN and what will happen to creatinine? Write down the answer, stop the video. Well, I'm sure you've written the answer by now. So patient who is on totally carbohydrate diet, his BUN will definitely get reduced. Why? As I just told you, BUN is come from exogenous protein. So here BUN will go down, but creatinine will increase. Why? As protein intake is absolutely 0, then endogenous protein which come from muscle will be broken down and will produce creatinine. So this is one condition where BUN is reduced and creatinine is will increase. That's why protein should never be 100% stopped in case of chronic any renal disease. Now I have one more question for you. Tell me any other condition where we know that BUN will be reduced and creatinine will increase out of proportion. Stop the video, write down the answer. Well, I'm sure you written the answer. Answer is liver disease. In liver disease also, what's the basic concept? Why this happened? Let's learn the basic. We all know very well that CO2 combined with ammonia and it makes urea. And this reaction occurs in liver. Okay? So now if liver disease is there, this reaction will not happen. CO2 will go out of the body. And it's the ammonia which will go and lead to all the problem of so-called hepatic encephalopathy. Since urea is not getting synthesized, urea level will go down. But creatinine which is being produced from endogenous protein will rise. So in liver disease also, creatinine will be higher as compared to, relatively higher as compared to urea. And one more condition where creatinine is out of proportion to urea is very muscular body. Very muscular body, normal person with a very high muscle, like those who fight that fight a big muscular body, they also have a higher creatinine as compared to urea because bulk of muscle is very high, so they produce more and more endogenous creatinine. Question number 142. Why do patients with carcinoid syndrome develop pellagra? The answer is niacin deficiency. For that, let's learn the basic concept. Normally, if you go for biochemistry of tryptophan metabolism, tryptophan is converted to niacin. This is normal reaction. But in case of carcinoid syndrome, this tryptophan is converted into serotonin. And it is this molecule which causes flushing and all the problem whatever we have with carcinoid syndrome. But at the same time, as more and more serotonin is being produced, definitely the reaction is diverted toward this side, and that will lead to deficiency of niacin. And when niacin deficiency occurs, then the patient develops feature of pellagra, that is dermatitis, diarrhea, and dementia. 3 Ds. Now one more thing, there's one condition where dementia is there, but what is special thing about this dementia? This is reversible dementia. It's very frequently asked question. So whenever we have to talk about reversible dementia, you should never forget about the important cause of reversible dementia. So reversible dementia causes are: number 1, hypothyroid; number 2, vitamin B12 deficiency; third, niacin deficiency; number 4, subdural hematoma; number 5, Whipple disease. They are very, very important cause of reversible dementia. Out of these 2 are, can't afford to forget this thing. Forgetting these 2 names is a big crime. That's very frequently asked question. Okay? So I hope you are clear about question number 142. Now we talk about question number 143. What lesion we are seeing? Well, if you look into this diagram, you can see that in this picture, you are getting this are the height of finger, and these 2, 4th and 5th finger are very short as compared to other. And this is classically seen in pseudo and pseudohypoparathyroid. Pseudo and pseudo hypoparathyroid. Okay. In fact, like in this case, we have the options of pseudohypoparathyroid 143. The option is B. Now let's learn about pseudohypoparathyroid. The pseudohypoparathyroid is a congenital disorder where tissues are resistant to action of PTH. With the result, PTH level is high, but serum calcium is reduced. Okay? And in these patients, classically you get short 4th and 5th metacarpal and metatarsal, as I showed in the picture also. This is a picture of pseudohypoparathyroid. The other options are rheumatoid arthritis. Rheumatoid arthritis, this thing doesn't happen. And the other option are osteoarthrosis. Normally the knee joint are involved, and they don't have shortening of 4th and 5th metacarpal. And same psoriasis also, they have a skin reaction, they have a nail involvement, and these are not seen in the picture. So best answer is B, Bombay, pseudohypoparathyroid. Now we talk about question number 144. Parkinson disease, most useful in the management of tremors. Well, the answer is, we know very well that in case of benzoxazole is the best answer, D. What is a benzoxazole? It is an anticholinergic drug. Well, we learned the basic concept. We have a triad in case of Parkinson. The triad include hypokinesia, we have tremors, and we have rigidity. These 2, they respond best to the dopaminergic drug. And this respond very well to anticholinergic drug. Now, before I discuss this question, let's learn some basic concept about Parkinson. Look at me. We all know that in case of Parkinson, nigrostriatal pathway is involved. Nigrostriatal pathway, this is dopamine and this is acetylcholine. Normally they are in balance. Now in Parkinson, this dopamine level goes down. There is imbalance between the dopamine and acetylcholine. So in the treatment, we want to maintain a normal. Either we give a dopaminergic drug or we give a anticholinergic drug. And that's the basic idea of giving dopaminergic drug and anticholinergic drug. And out of the three main problems, as I told you, tremor respond very well to anticholinergic drug. That's why we give benzoxazole, which is nothing but a type of anticholinergic drug for the patient, as I just described. So question 144, the best answer is anticholinergic drug, benzoxazole. Question number 145. A 23-year-old lady come with lethargy, blood investigation show you HB 10 gram, TLC, platelet 2.7, MCV is 65, okay, and as far as so-called HbA2 is 4.5, what is the most likely diagnosis? The answer here is this, the best answer, C. So before I discuss this question, let me tell you some basic concept about beta thalassemia. This is not known to most of students. So thalassemia. Basic concept. Well, in the normal adult, we have HbA, hemoglobin A. It is about 95 to 96%. I'm talking about adults. And these are 2 alpha, 2 beta chains. Then HbA2, 1 to 3%. 2 alpha, 2 delta chains. Then HbF, 2 alpha and 2 gamma chain, less than 1%. So if you do the normal electrophoresis, hemoglobin electrophoresis, you get a picture like this, A2F, A2F. Now in beta thalassemia, this beta chain is not there, okay? A beta chain is not there. So in the definitely in case of, and the HbA level will be reduced. Body try to compensate by making more and more A2 and more F. So now if you do electrophoresis, you get like this, A2F. The raised level of hemoglobin F in the adult is one of the diagnostic feature of beta thalassemia. Now, this much is known to most of students, but most of people are confused about minor, intermediate, and major. So that we'll talk about. So now let me go into more depth of the subject. Again, basic concept. Beta chain, there are 2 beta chains, alpha 2, beta 2, that means there are 2 chains. Each chain is controlled by 1 gene. 1 gene, 1 chain. That means beta chain will be controlled by 2 genes, okay? So now, if gene is made, if both the chains are normal, suppose the gene is normal, and that means normal gene means normal synthesis of beta chain. So we write as beta. This means the beta chain has been, single chain has been made perfectly all right. And if beta chain is not formed at all, then we call it to be 0. 0 means beta chain is not formed at all. But maybe partial synthesis of beta chain occurs. So we call as B+. But what I want to make you note that this B+ is in relation to B0, not in relation to B, which is normal. N for normal. Here it is P for partial. The chain is made partially, and it is and beta 0. That means there is complete absence of urine. I write A for absence beta chain. I can even give a better example. Let's give a value of 0 paisa to beta 0. 0 paisa. This I give as 50 paisa, and this guy give value of 100 paisa. That is 1 rupee. With this basic, now let's talk about a beta, suppose, and remember there are two chains. Both the chains are not made, so you get beta 0, beta 0. And this is beta thalassemia major. Major means both the chains are not formed. And what will the value of this answer will be 0 paise. 0 paisa is 0 paisa. Now, suppose I get one chain like this. B 0 B. Okay. Or, and I can get like the B plus. Or I get B plus. B0 B plus. Okay. Let us see how much the value. In this case 0 and 100 paisa, value will be 100 paisa. This is 50 paisa, value will be 100 paisa. So we are getting 100 paisa as the value. This is beta thalassemia intermedia. This was major and this is intermedia. And here value is 100 paisa and 50 paisa. Value is 150 paisa. 150 paisa. And this we call as thalassemia minor or trade. Friend, this is the most confusing thing in the entire hematology. And if you read any book, there's a lot of overlapping is there. That's why this is not understood by anybody. Most of you don't get confused. But I have given you the most simplified version by the value of money. So 0 is major, 100 paisa is minor, intermediate, and 150 paisa is minor or trade. So we can sing a song like this also. 100 paisa is rupaya, 1 rupaya, or 1.5 rupaya. So we can sing a song like this. 0 rupaya, 1.5 rupaya is beta thalassemia. Okay, 0 rupaya, 1.5 rupaya is beta thalassemia. Well, majority this come in the DD of iron deficiency anemia. Very, very important question. Okay, and in this condition, there are two things you got to remember. First of all, MCV is reduced out of proportion to MCH. This is one thing which is not seen in iron deficiency anemia. And one more thing here, HbA2 is normal is 1 to 3, but it is usually more than 3%. But HbF is normal. So in this condition, the question, hemoglobin is 10 gram. 10 gram is the hemoglobin, not like a major issue of the anemia, but MCV is highly reduced. It's highly reduced. And HbA2 is increased. Hence, this is the best answer. Why can't be this the problem? In this case, HB is much more reduced, and this A2 is much higher, maybe 10, 15, 20. This is not the answer. Sickle cell anemia doesn't have this type of picture, and hereditary spherocytosis doesn't have this type of picture. They all together have different, this you can diagnose on peripheral smear. And peripheral smear is not mentioned, and there is no history suggestive of this. And MCV is not out of proportion reduced in sickle cell and hereditary spherocytosis. Now, Samprilat, it is used for which condition? It is used for congestive heart failure. Okay. It's a new drug for CHF. Now, let me tell you what are the other drugs which are newer drug for CHF. The other new drug for CHF are new drug for CHF. Congestive heart failure, levosimendan, nasiteride, this is a BNP analog, Eplerenone, is just like spironolactone is aldosterone antagonist, but advantage is it does not lead to gynecomastia. Eplerenone. Then we have something very interesting, coenzyme Q. It is not a drug for CHF, but we use in CHF. I mean, if we use in CHF, the outcome becomes much better. Otherwise, it's not a direct drug for CHF. Now I have a question for you. Stop the video, write down the answer. Tell me, in which other condition we use, especially in neurology, to be more precise, where we use coenzyme Q as a prophylactic drug. Which, okay, write down the answer. Well, I'm sure you have written the answer. Answer is Parkinsonism. In Parkinson disease also, or Parkinsonism, what they say, if you use coenzyme Q, it reduces the progression of a degeneration in Parkinson. So we continue. So other new drug is Mecarbel. Okay, this is a direct myosin activator. Mecarbel. So these are some of the newer drugs for congestive heart failure. Well, we got another beautiful picture where we are getting furrows in the tongue, so-called triple furrow, what we call as triple furrow is seen. The triple furrow is not seen in HIV. Righto? We can see furrows, what word we use it, triple furrow. This is seen in condition what I mentioned you. Now let me tell you certain other abnormality of the tongue. We get macroglossia, enlarged tongue. This we see in hypothyroid. We see beefy tongue, beef-like tongue. This we see in B12 deficiency. Okay. Then smooth tongue in iron deficiency anemia. And now come the rank number 1 question, very frequently asked question. Stop the video, write down the answer. The question is, in which condition you get strawberry tongue? Well, I'm sure you've written the answer by now. The answer is, we see strawberry tongue in Kawasaki disease. And we also get strawberry gums in vaginous granulomatosis. This is all extra knowledge for you. Question 148. Pick up the 2 statement about anion gap. So before that, let me discuss the basic concept about anion gap. Then we see what the answer is. Anion gap. How we really calculate anion gap? It is sodium minus chloride plus bicarbonate. Point to be noted, in this case, we do not include potassium. So normal 135 minus chloride is 104, bicarb is 24, 135 minus 128, this comes out to be plus 7. Now in this equation we are getting 7 extra particles. Okay, and we know very well that in the universe positive and negative are always equal as per law of electrostat. But here we are getting 7 extra positive particles. It means there are certain other negative particles which are there, which we have not taken into consideration. So the negative particles which we have not taken into consideration are A for albumin. Albumin is a negative charge, sulfate, phosphate, lactate. All these are negative particles and many more also. So now they all will constitute about 7 minus. This is how this figure will be neutralized. So that means if somebody asks you what is the anion gap, so you can say it's the measurement of unmeasured anions. You can leave 3 lines and write down. So anion gap is the measurement of unmeasured anions, like as I mentioned, right? So normal anion gap is 6 to 12. Now let me talk more about it. Suppose I get one, of course we come back to this figure. I get one patient whose sodium is 135. He has normal chloride, but he has metabolic acidosis. How do you know? Bicarb rate is reduced. It has gone to 14. So now the anion gap is how much? Plus 17. Plus 17, anion gap is increased. Normally 6 to 12. So in metabolic acidosis, anion gap is increased. Now I have one more situation. 135 minus 14. Patient has metabolic acidosis. But I want anion gap to remain normal. Is it possible? Write down the answer. Is it possible to have normal anion gap? Yes, if chloride becomes 114. So we have normal anion gap. It means what? We have 2 types of metabolic acidosis. One with increased anion gap and other is normal anion gap. And this is also known as hyperchloremic metabolic acidosis. With this background of basic concept, now let's look into answer option. Pick up the 2 statement of anion gap. Normal anion gap 15 to 20, not at all. It is 6 to 12, out. It represents unmeasured anion in plasma, true. Increase in serum calcium will increase the anion gap. No, it will reduce the anion gap. Wrong. Anion gap is sodium. No, they are not included. The best answer is B is the best answer. Question 49. Which of the following score is used for liver for prognostication? What we use is discrimination factor. Discrimination factor is classically used when we plan to start glucocorticosteroid. CS stands for corticosteroid therapy in a case of alcoholic hepatitis. Let's discuss the basic concept about alcoholic liver disease. First of all, alcoholic liver disease occur only in chronic alcoholics, okay, not in acute cases. And number 2, in the alcoholic liver disease as such, there are 3 stages. One is fatty liver, other is hepatitis, and third is cirrhosis. And in fatty liver, of course, the best treatment in all the stages is stoppage of alcohol. But in cirrhosis of liver has occurred, then treatment is only symptomatic. But when hepatitis stage is there, then we can think of giving corticosteroid. But that we give only when we use discriminant factor, and with this use when the discriminant score is more than 32. Okay. MELD score is used when we plan to go for liver transplantation. Child PUG score is again used to know the severity of a chronic liver disease. These are the things. So for alcoholic liver disease, we use discriminant factor. Eye sign. Well, it's a beautiful question, and this question comes almost every year. What we are getting in X-ray? We are getting bamboo spine. Why this happen? This calcification of intervertebral ligament. I can draw this vertebra. and these are the intervertebral ligament. These get calcified, and we get a picture like this. We get bamboo spine. And this is seen in ankylosing spondylitis. In ankylosing spondylitis, there are certain extra articular feature, and of this, anterior uveitis is the most common manifestation. It is seen in around 30% cases of ankylosing spondylitis. That can lead to acute red eye also. Okay. Other thing that you should know in ankylosing spondylitis is the patient may have anthesis. Anthesis is the It's the point of attachment of bone to tendon is painful. Tendon, bone attachment. This is painful. And classically, this pain occurs in costochondritis. Costochondritis will lead to pain chest. It can lead to plantar fasciitis, can lead to heel pain, and can lead to tendoacheilitis, and can lead to ankle pain. All these occur due to anthesis. Okay? And of course, in ankylosing spondylitis, HLA-B27 is positive. B27 is positive. And the commonest joint is sacroiliac joint. That's why low backache is the most common presenting feature. Low backache. The most common presenting feature is of ankylosing spondylitis. Now we talk about question 151. What is the best treatment for hepatorenal syndrome? The answer is liver transplantation. Okay. Why liver transplantation? And this you will never understand unless you know the basic concept about hepatorenal syndrome. Well, in hepatorenal syndrome is a type of hepatorenal syndrome. This is a type of functional renal failure. This occurs in those patients who have a severe liver disease. What do you mean by functional liver disease? The kidneys are not functioning in the patient body, that's why urea creatinine is raised. But you take out the kidney and you transplant in some other patient who have got renal failure due to whatever cause it may be. They work very well there. And that's why we call it functional renal failure. And this all occur due to abnormal environment due to liver disease. So in these cases, if you do the liver transplantation, once the environment gets correct and this kidney is already, and they start functioning because there is no problem in the kidneys. That's why the best answer for this case is liver transplantation. There is no advantage of doing kidney transplantation, because even if you do only kidney transplantation without liver transplantation, patient will not survive because there is no problem in the kidney as such. Liver transplantation is the best answer in this case. Okay. Now we talk about question number 152. Well, metabolic complication of CRF include all except hypophosphatemia is not a feature. Hyperkalemia can occur. Hypocalcemia is a very feature, and something very interestingly, even hypokalemia can occur. Most of people get confused with this thing because there are two things, hyper and hypokalemia. Yes, potassium level can even be normal also. Well, in which type of chronic renal failure where we can have hypokalemia? Especially common in those conditions where CRF occur due to tubulointerstitial disease. T for tubulointerstitial disease. The chronic TID can lead to tubular dysfunction, can lead to salt wasting nephropathy. In such cases, there is salt wasting nephropathy, and that can lead to hypokalemia also. Now, in these patients, hyperphosphatemia occurs. not hypophosphatemia. And of course, hypocalcemia occur. Why? Why hypocalcemia? Because in these cases, vitamin D deficiency is occur. Why vitamin D deficiency? Again, we learn the basic concept. We all know very well that in vitamin D synthesis, 25 hydroxylation occurs in the liver, and 125 hydroxylation occurs in the kidneys. And as the kidneys are not functioning, the 125 hydroxylation not occurring, vitamin D level will go down. Vitamin D level will go down, there will reduce calcium absorption from GIT, and that's why hypocalcemia occurs. And that leads to increased PTH. So there is secondary hyperparathyroid. It's secondary hyperparathyroid due to CRF. The classical finding is low calcium and in high phosphate. Low calcium and high phosphate. This is secondary hyperparathyroid due to CRF. But remember, secondary hyperparathyroid due to nutritional ricket and osteomalacia can also lead to secondary hyperparathyroid. In those cases, calcium level is reduced, even phosphate level is also reduced, but PTH level remain high. So that means the difference between nutritional type of secondary and the CRF is phosphate level. In CRF, phosphate is high, nutrition phosphate level are also low. Okay, so I hope you are clear about this question also. Now the question 153 is a lovely question. We are getting multiple miliary shadow, and this is classically that we see in case of miliary tuberculosis. Lovely photo. Okay, bronchiectasis have a ring sign, ring shadow. They don't have like this thing. Pneumonias, they have a lobar pneumonia. They don't have this type of picture. Even endobronchial tuberculosis will not have a miliary shadow in both lung parenchyma. Now, one more question. Again, it's a rank number 1 question. Stop the video, write down the answer. In miliary tuberculosis, how much is the hemoptysis? Number 1, none, mild, moderate, severe. How much is the hemoptysis? None, no hemoptysis, mild, moderate, severe. Write down the answer. Well, the right answer is none. Hemoptysis is not a feature of miliary tuberculosis. In fact, most of the time, miliary tuberculosis is totally asymptomatic. And miliary tuberculosis is diagnosed incidentally. Incidentally means we just investigate, do chest X-ray, and you find multiple miliary shadows there. This is how we pick up miliary tuberculosis. And of course, the main danger of miliary is it can disseminate to so many other places. It can lead to TBM. It can lead to bone of the bony tuberculosis. It can go to adrenal gland. So it can disseminate to so many other places. Well, what are extra point that you got to know about miliary tuberculosis? In miliary tuberculosis, Monto's test may be negative. It's a very, very important point. Other condition where Monto test is negative is HIV, sarcoidosis, patient on corticosteroid therapy, patient having immunosuppressive therapy, patient having acute illness, especially measles. In such cases, this thing, Monto's test is negative. Okay, so this is all about medicine discussion, grand test question discussion, and as I told you, I have written a book, Medicine Simplified, which is a mini Harrison, and I've got this a textbook for undergraduate and for those who are doing preparing for PG enters. I got Medicine Essence, which is a question bank, both based on 20th edition of Harrison. Both are available on a highly discounted price on Amazon. And I also recorded Medicine E-Gurukul, ultimate lectures of the entire medicine. If you want, you can take it. And for that, you have to visit our website. And website details are given in all our Gantt tests. Anyway, I hope you learned a lot from this Gantt test discussion. We have a limited time, but still I try to give as much extra information I can. Thank you very much for watching this video.